Welcome to episode 3 of Functional Neurosurgery Explained. Today, we ask one big question. When the brain is sending the wrong signals, do we destroy the source or do we change its behavior? Two approaches, two completely different philosophies. The first is neuroablation, permanently destroying a brain target. No going back. The second is neuromodulation, using electrical stimulation to change how that target behaves. Reversible, adjustable, controllable. We will explore both through the lens of Parkinson's disease, one of the best studied conditions in functional neurosurgery. Let us begin. For decades, Parkinson's disease was understood as one simple problem: missing dopamine. The substantia nigra compacta, a small area deep in the brain, slowly loses its neurons. These neurons produce dopamine. Without it, 3 symptoms appear among others: slowness of movement, muscle stiffness, and a resting tremor. The logical treatment: replace the dopamine. That is exactly what levodopa does, and it worked well at first. But over time, questions appeared that dopamine alone could not answer. Why do symptoms fluctuate unpredictably? Why do surgeries that never restore dopamine still dramatically improve symptoms? These were important clues. They were telling us the real problem was not just a missing chemical. It was something deeper. It was the circuit. For decades, Parkinson's disease was understood as one simple problem: missing dopamine. The substantia nigra compacta, a small area deep in the brain, slowly loses its neurons. These neurons produce dopamine. Without it, 3 symptoms appear among others: slowness of movement, muscle stiffness, and a resting tremor. The logical treatment: replace the dopamine. That is exactly what levodopa does, and it worked well at first. But over time, questions appeared that dopamine alone could not answer. Why do symptoms fluctuate unpredictably? Why do surgeries that never restore dopamine still dramatically improve symptoms? These were important clues. They were telling us the real problem was not just a missing chemical. It was something deeper. It was the circuit. Think of the basal ganglia circuit as a relay race. It starts at the motor cortex, the brain's movement decision center. The signal passes to the striatum, then through 2 key stations. The first is the GPE, the external globus pallidus. The second is the STN, the subthalamic nucleus. These 2 structures process and filter the signal before passing it forward. The signal then reaches the main output stations, the GPI, the internal globus pallidus, and the SNR, the substantia nigra pars reticulata. These decide what message gets sent next. Finally, the signal arrives at the thalamus, which sends it back to the motor cortex, and movement happens. Think of your brain as a car with 2 systems, a go pedal and a brake. The direct pathway is the go system. Dopamine activates it. The GPI is suppressed. The thalamus is released, and movement happens. The indirect pathway is the brake. Dopamine normally keeps it quiet. But without dopamine, this pathway overactivates the STN, which drives the GPI to maximally suppress the thalamus. The brake gets stuck on. In Parkinson's, the go signal weakens and the brake dominates, producing slowness, stiffness, and difficulty initiating movement. So the surgical logic is clear. Fix the brake. Either cut the brake cable permanently, that is ablation, or control it electronically, that is neuromodulation. Here is the most important insight of this episode. In Parkinson's disease, the subthalamic nucleus, The STN is structurally normal. No cell death, no damage. It looks perfectly healthy. But it is firing completely wrong. When dopamine disappears, the GPE loses control over the STN. The STN is suddenly free to burst, fast, synchronized, pathological bursts of beta waves that block movement. There is also a direct shortcut called the hyperdirect pathway, a fast connection straight from the cortex to the STN that makes this loop even stronger. Now ask yourself this: if the STN is structurally healthy, if the behavior is the problem, not the structure itself, why would we ever destroy it? Why not simply correct its behavior? That question is the entire foundation of DBS. Before DBS existed, surgeons had only one surgical tool: destruction. In the 1950s, thalamotomy was introduced. Surgeons permanently destroyed part of the thalamus. For tremor, it worked remarkably well, but the result was forever. Any mistake was also forever. Levodopa arrived in the 1960s and surgery was largely abandoned. Why operate when a pill works? By the 1990s, long-term levodopa problems brought surgery back. Pallidotomy, destroying part of the GPI, helped. But bilateral surgery caused speech and swallowing problems that were also permanent. Ablation confirmed the circuit model was correct. Targeting the right structure did improve symptoms. But Parkinson's is a progressive disease. The fixed lesion could not evolve with it. The disease moved forward. The treatment stayed still. The year is 1987. Grenoble, France. Dr. Alim Louis Benabid is mapping the brain before a thalamotomy. Standard procedure. He delivers electrical stimulation to locate the target. Then he increases the frequency, above 100 pulses per second. The tremor stops immediately, without destroying anything. He had just discovered that high-frequency stimulation could mimic a lesion. Reversibly, look at the two images on this slide: a scalpel destroying a target, an electrode stimulating a target. Same clinical result. Completely different philosophy. One is permanent. The other can be turned off, adjusted, and improved. That single discovery shifted the functional neurosurgery forever. Let us compare both approaches directly. Reversibility, ablation is permanent. DBS can be switched off at any time. Adjustability, a lesion is fixed forever. DBS is reprogrammed at every clinic visit as the disease progresses. Bilateral safety. Bilateral ablation carries serious risks of speech and swallowing problems, while DBS is applied routinely bilateral. Effect on tissue. Ablation destroys the target. DBS preserves it and only changes its behavior. And the evidence is clear. The early STEM trial in 2013, published in the New England Journal of Medicine, showed that patients who received early DBS had dramatically better quality of life compared to those on medication alone. Not just better movement scores, better quality of life. Traditional DBS has one limitation. It delivers the same stimulation all the time, whether the patient is sleeping, walking, or eating. It does not know what the brain needs in that moment. The future is adaptive DBS, also called closed-loop DBS. Here is how it works. The electrode simultaneously listens to the brain's electrical activity. When it detects a pathological beta burst, a sign that symptoms are about to worsen, stimulation is triggered automatically. When the brain normalizes, stimulation reduces. The device becomes a conversation between the electrode and the patient's own brain. The result? Longer battery life, fewer side effects, truly personalized therapy. responding to each patient's unique brain in real time. This is the future, and it is already here. Let us close with 5 things to remember. 1. Parkinson's is a circuit disorder, not just a chemical deficiency. 2. Motor symptoms are driven by abnormal beta oscillations in the basal ganglia network. 3. Neuroablation proved the circuit model worked, but was too rigid to adapt as the disease progressed. 4. Neuromodulation achieves the same benefit while preserving tissue, allowing adjustment, and enabling safe bilateral treatment. 5. The future belongs to adaptive closed-loop systems that respond to the patient's own brain signals in real time. In episode 4, we go inside the electrode. How does electrical stimulation actually change the way a circuit fires? What happens at the nerve fiber, at the synapse? See you in the next episode.